Patient's here.
Oh boy, got some blood going.
Yeah, there's blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application
for 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Usually, when you talk about a medical diagnosis, there's this comforting expectation of precision, right? Like, it's like engineering.
Right. Yeah.
You break your arm, the x-ray shows that jagged white line, the doctor points to it, and the treatment plan is obvious. You just fix the bone.
It's incredibly binary. I mean, broken or not broken. In acute medical care, we really rely on things being visible and neatly categorized.
Yeah, but the moment you step onto a psychiatric floor for your clinicals, well, that x-ray machine is entirely useless. You are suddenly looking at a diagnostic landscape that is, frankly, incredibly murky.
Extremely murky.
And if you are a nursing student listening to this right now, preparing for your boards or your next clinical rotation, navigating those muddy waters is exactly what we are doing today.
That's the goal.
We are looking at a stack of sources covering obsessive-compulsive and related disorders. And our mission is to filter this through the 80-20 rule. We're pulling out the highest yield 20% of the pathophysiology, the safety risks, and the meds that will give you 80% of the clinical judgment you actually need to care for these patients safely.
And, to pass those exams, we are going to decode the psychiatric nursing model. Because instead of just memorizing textbook definitions, you really need to understand the underlying mechanisms.
Right.
When you know why a patient is exhibiting a behavior, you know exactly what to look for, what to say, and how to spot the traps in those really tricky multiple choice questions.
Okay, let's unpack this. Let's anchor this whole discussion with the core distinction. People use the term OCD casually all the time.
Oh, constantly.
Say they're so OCD about their desk being organized. But clinically, this disorder is devastating, and it breaks down into two distinct halves, the obsession and the compulsion.
Yeah, and that distinction is absolutely vital. The obsession is purely internal. These are recurrent, persistent, highly intrusive, and completely unwanted thoughts, images, or impulses. And they cause a staggering level of anxiety.
Wow.
The compulsion, on the other hand, is the external behavior, or sometimes the mental act.
So like the repetitive hand washing or the counting?
Exactly. Hand washing, counting, praying. The patient feels utterly driven to perform this compulsion as a way to neutralize the overwhelming anxiety caused by the obsession.
So, the obsession is the terrifying thought, and the compulsion is the action they take to try and turn the terror off.
You've got it.
Which brings up a scenario that I think trips up a lot of new nurses. If you walk into a patient's room, and they are washing their hands so obsessively that their skin is raw and actively bleeding.
Yeah, I know where you're going with this.
Every medical instinct screams at you to stop the bleeding. You would logically want to step in, turn off the sink, and tell them to stop.
And doing that would trigger the biggest safety hazard and the most common exam trap on the board. You can never simply tell a patient with OCD to stop their ritual.
Wait, really?
Yeah, you absolutely cannot force an initial interruption of that behavior.
Even if they are causing themselves physical harm, because that feels completely counterintuitive to basic nursing care.
I know, it feels so wrong until you understand the psychological mechanism at play. See, that compulsion is currently their only coping mechanism. It is the single tool they possess to ward off a level of anxiety that feels genuinely life-threatening to them.
Oh, wow.
If you abruptly step in and interrupt that ritual, the anxiety doesn't just stay stagnant, it spikes into sheer, unmanageable panic. You basically escalate the situation completely out of control.
Okay, that makes sense.
So when you are tested on this, the logic always points toward the least restrictive and most empathetic intervention. Any answer choice that says, interrupt the ritual or lock the bathroom door so they can't wash, is a distractor. It is always incorrect.
Okay, so the absolute must-know safety rule is never abruptly stopping a ritual. But to really grasp why their anxiety is that high in the first place, we have to look at what is actually happening inside their brain.
Yes, let's look at the cognitive model.
Aaron Beck's cognitive model shed some really interesting light on this. The source material talks about how patients with OCD often have this inflated sense of personal responsibility, sometimes stemming from very strict moral or religious upbringings,
Right.
combined with an absolute intolerance for uncertainty. They experience something called thought-action fusion, where they subconsciously believe, if I think this terrible thing, it will actually happen.
That cognitive distortion is profound.
Well-
The brain fails to separate the thought of a disastrous event from the actual execution of it.
It makes me think of like a broken email spam filter.
Oh, that's a good way to put it.
Because every single person on Earth gets weird, random, intrusive thoughts. You're driving over a bridge, and your brain suddenly says, what if I just drove off?
Yeah, exactly.
But a healthy brain automatically routes that thought to the junk folder. You barely even register it. But for someone with OCD, their brain marks every single one of those spam emails as urgent and life-threatening, and it just sets off all the physiological alarm bells.
And the physiological response of terror is entirely real to them, even if the threat isn't. And there are substantial biological risk factors driving this broken filter, too. Population-based studies confirm a strong genetic heritability.
So it's passed down.
Yeah, it's a complex network of genes, not just one, but the biological predisposition is undeniable.
I was looking at the demographics, and it seems to affect men and women equally overall, about a 1 to 2% prevalence globally. But the onset is where it diverges, right?
Right.
Like if it starts in childhood, it's more common in males and usually presents with much more severe symptoms. If it begins in their 20s, it's more common in females.
And the cultural context matters immensely here, too. I mean, OCD is a universal human disorder, but culture dictates how it presents. In highly religious cultures, a patient might experience intense, crippling guilt because they believe they should be able to control intrusive, blasphemous thoughts.
Right.
They might interpret the obsession as a moral failing or even, a supernatural attack, leading them to seek out faith healers rather than psychiatric care.
Which means they're suffering in total silence. The shame attached to these thoughts is so heavy that patients often go to incredible lengths to hide their symptoms.
Yeah, they do.
They might endure this secret torment for years before ever showing up in a clinical setting.
Which brings us to your priority nursing assessment. When they finally do arrive, you have to separate your subjective and objective findings. Subjectively, the most heartbreaking thing you'll hear is a patient saying they feel like they are going crazy.
Because they know it's not normal.
Exactly.
Yeah.
Unlike some other psychiatric conditions, a patient with OCD has completely intact memory and intellect. They are painfully aware that their rituals are excessive and irrational. They know it doesn't make sense to lock the door 40 times, but they cannot stop.
That self-awareness is the breeding ground for all that shame.
It is.
And objectively, when I'm looking at them, beyond just seeing someone who is tense and worried, what am I actually prioritizing? Because yes, the anxiety is sky high, but as a nurse, I have to look at the physical toll this is taking.
That is a great instinct. Your priority assessment, and this is a major concept for clinical judgment, is their physical health and their activities of daily living, or ADLs.
Okay, ADLs.
You have to evaluate if the rituals are eclipsing basic survival needs. Are they ignoring extreme hunger because a counting ritual has to be finished first?
Right.
Are there nighttime compulsions preventing them from sleeping? Are they developing severe secondary infections from compulsive skin scrubbing? You're always assessing how the psychiatric symptom is threatening physical safety.
That makes perfect sense. But here's where it gets really interesting. There's a massive red flag in the source material regarding the age of onset that completely changes that assessment priority.
Oh, yes.
If you have a patient who suddenly develops OCD symptoms for the very first time, but they're over the age of 50, that changes everything, doesn't it?
It changes the entire trajectory of care. The initial onset of OCD after age 50 is exceedingly rare. If you are assessing an older adult who newly acquires obsessive or compulsive behaviors, your clinical judgment must immediately pivot away from a primary psychiatric diagnosis and toward an organic brain issue.
Meaning there is a physical, structural problem causing the psychiatric symptom.
Precisely. You have to initiate immediate medical follow-up to rule out infections, degenerative disorders, brain injuries, or cerebrovascular lesions like strokes or tumors.
Specifically affecting the frontal lobes or the basal ganglia.
Right, yes. The psychiatric symptom is just the alarm bell for a medical emergency.
Okay, assuming we've ruled out an organic issue and we are treating a standard case of OCD, how do we actually intervene safely? We established that we can't force them to stop their rituals, so what do we actually do?
This is where milieu management, controlling the patient's environment and schedule, becomes critical. And initially, it requires an intervention that feels wrong to a lot of students. You actually allow extra time for their rituals and their daily schedule.
Yeah, I really struggle with this concept. If we are penciling in a 45-minute block for them to wash their hands before breakfast, aren't we just enabling the pathology? Like, how does a patient ever recover if the hospital schedule accommodates the disease?
It looks like enabling, but it's actually establishing a strategic baseline. You cannot strip away a coping mechanism before you've built a new one.
Okay.
If you don't schedule that 45 minutes, they just skip breakfast, and now you have a nutritional deficit on top of the anxiety. You accommodate to maintain their ADLs initially, but you don't stay there. That accommodation is the launchpad for ERP exposure and response prevention.
Okay, so how does ERP actually rewire that broken cognitive spam filter?
Well, it's a process of habituation. Exposure means you work collaboratively with the patient to deliberately confront the stimuli they usually avoid, like, say, touching a contaminated doorknob.
Right.
Response prevention is the critical second half. It involves delaying the performance of the ritual. They touch the doorknob, and then they must wait 5 minutes before washing their hands.
Oh, wow.
Over time, they realize that the catastrophic event they were convinced would happen, it doesn't. They learn to tolerate the anxiety spike, and eventually the baseline anxiety lowers.
But ERP sounds like psychological torture if a patient is already operating at a 10 out of 10 anxiety level. I mean, we have to bring that baseline reactivity down before they can even engage in therapy, right?
Right.
Before the pharmacology comes in.
Exactly. Therapy is grueling if the brain chemistry is working against you. The absolute must-know first-line medications for OCD are the SSRI antidepressants. The source material highlights fluvoxamine, which is Luvox, and sertraline, which is Zoloft.
Let's unpack the mechanism there, because it's not immediately obvious why an antidepressant fixes a compulsion. SSRIs block the reabsorption of serotonin, leaving more of it available in the synaptic cleft. How does that extra serotonin help an OCD brain?
Well, serotonin is a major mood and anxiety regulator. By increasing its availability, you are essentially cooling down that hyperactive corticostriato-thalamocortical loop.
The connection between the frontal lobe and the basal ganglia.
Exactly. It turns the volume down on the alarm bell just enough that the patient can actually utilize the behavioral strategies they learn in ERP.
And if the SSRIs aren't cutting it?
We step up to SNRIs like venlafaxine or Effexor. And for truly treatment-resistant OCD, we bring in second-generation antipsychotics like risperidone or aripiprazole to further modulate those neural pathways.
While the medications are doing their work neurochemically, the nurse is the one at the bedside providing therapeutic communication. And because these patients are so self-aware and carrying so much shame, what we say and what we don't say is absolutely vital.
The fundamental DO is to validate their overwhelming feelings without validating the delusion. You encourage them to talk about their secret rituals in detail. Just dragging those behaviors out into the light and realizing the nurse isn't horrified relieves a massive burden of shame.
It's the don'ts that I find really compelling, because there are things well-meaning people say all the time, like telling a patient, just think of something else. Or, you know, it doesn't make sense to check that lock again.
Yeah, never use logic to talk them out of an obsession. As we discussed, they already know it doesn't make sense. Their intellect is completely intact.
Right.
Reminding them that their behavior is irrational just highlights their loss of control, which drastically increases their guilt and alienation.
When you really internalize that core mechanism, that an overwhelming drive to neutralize anxiety is running the show, you start to see how this branches out into other disorders on the OCD spectrum. It's not always about checking locks or washing hands. Take hoarding disorder, for example. It's the same compulsive mechanism, but directed entirely at the acquisition and retention of objects.
And hoarding has a very different trajectory. I mean, OCD often starts young, but hoarding worsens significantly with age, affecting about 2 to 5% of the population.
Yeah.
They acquire useless items and cannot discard them, which turns their living spaces into massive health, fire, and safety hazards. It requires incredibly long-term cognitive behavioral therapy and usually the intervention of community agencies to keep the patient physically safe in their home.
So hoarding is an external focus. But what happens when that obsession turns completely inward onto the patient's own physical body? That brings us to body dysmorphic disorder, or BDD.
With BDD, the patient is utterly preoccupied with a slight or entirely imagined physical defect. They ruminate on this flaw, blaming it for every negative thing in their life. The critical exam tip for BDD is recognizing their behavioral pattern. These patients repeatedly seek out cosmetic surgery.
But the surgery doesn't fix the brain.
Never. The scalpel cannot cut out a psychiatric obsession. They wake up from surgery, and the psychological distress simply latches onto a new perceived flaw. The correct nursing and medical intervention is psychiatric care, specifically SSRIs to manage the underlying anxiety.
It's fascinating how the brain directs this anxious energy. With BDD, the distress is at a perceived flaw. But then there are the physical self-soothing behaviors like excoriation, trichotillomania, and onychophagia.
Right, so that's skin picking, hair pulling, and severe nail biting. Excoriation is mostly targeted at the face, arms, and hands, and it can be so severe it leads to medical complications requiring plastic surgery.
Oh, wow.
Trichotillomania is chronic hair pulling, which is more common in females, and is often treated with behavioral therapy and the SSRI clomipramine. These aren't just bad habits, they are desperate attempts to self-soothe intense anxiety.
And on the other end of the spectrum, instead of self-soothing, you have reward-seeking behaviors. Kleptomania and Oniomania, compulsive stealing and compulsive buying.
And the distinction here is the motivation. With kleptomania, the reward isn't the item they steal. I mean, they usually have the money to buy it, and they don't need it to survive.
Right, it's not about the object.
Exactly. The reward is the thrill of the theft itself, the release of tension. It carries a high comorbidity with depression and substance use. Oniomania operates similarly with shopping. The pleasure is in the acquisition, the swipe of the card, not the actual use of the object. It frequently starts in the early 20s and can lead to catastrophic financial ruin.
So what does this all mean? Whether a patient is hoarding newspapers, pulling their hair, or washing their hands until they bleed, the core nursing approach remains incredibly unified.
It does. You are treating the underlying anxiety, not just policing the bizarre behavior. You never shame them. You never force an abrupt stop to their coping mechanism because that induces panic.
Right.
You monitor constantly for physical safety, like treating skin infections from excoriation or addressing malnutrition, and you utilize SSRIs and ERP to gradually lower that baseline terror.
If you are taking your exam tomorrow or walking onto the psych floor for your shift, remember the 80-20 rule here. Safe psychiatric nursing care prioritizes physical safety and ADLs first. Always choose the least restrictive intervention. And above all, foster a non-judgmental environment so these patients can finally stop suffering in secret.
That is the essence of clinical judgment. You manage the anxiety so the patient can regain control of their life.
Before we wrap up, there is one more related disorder mentioned in the source material that is, frankly, fascinating and a little unsettling to think about. It's called Body Identity Integrity Disorder, or BID. People with BID feel profoundly alienated from a perfectly healthy body part. They literally desire amputation.
It is an extreme manifestation. They report feeling sheer anguish over having an intact, healthy body. And because it goes against every tenet of medical ethics for a surgeon to amputate a healthy limb just because a patient requests it, these individuals sometimes take matters into their own hands.
Yeah, the text mentions horrifying scenarios where they might pack the healthy limb in dry ice until the tissue damage is so severe that amputation becomes a medical necessity. Or they use power tools, forcing a physician to intervene to save their life.
It's terrible.
It brings us full circle to that X-ray metaphor we started with. If a bone is shattered, the medical fix is obvious. But with BID, the physical body is perfectly healthy, yet the psychological distress is what's demanding the amputation.
It creates a profound ethical dilemma for any healthcare provider involved.
It really does. We want to leave you with this to mull over. In a modern medical world where we heavily prioritize patient autonomy and the right to choose your own care, how should healthcare professionals navigate a patient who genuinely feels their body is only correct if it's permanently altered or disabled? Where exactly do we draw the line between providing psychiatric care and performing a surgical intervention?
It's not a question with an easy answer, but it's the kind of complex clinical reality you will face as you grow in this profession.
Thank you so much for joining us on this deep dive. Carry this knowledge, this critical thinking, and this empathy into your next shift and your next exam. You've got this.